presently as HOD and Senior Consultant in Cardiology at Sreechand Speciality Hospital. Dr. Raveendran did his MBBS in 1984 and MD in General Medicine in 1989 from Calicut Government Medical College. Following which he did DNB in Cardiology in 2005. He is a Fellow of Society for Cardiovascular Angiography and Intervention. He got their fellowship in 2014. Previously, he has worked as a consultant cardiologist in Sagarna Hridayalaya, Pariyaram. Before that, he was a professor of medicine in Koili Hospital, Kannur. He worked as a consultant cardiologist in Kannur Medical College, Ancharakandi. And he worked as a consultant cardiologist at Astra Medical Center, Doha, Qatar, and Jim Care Hospital, Kannur. He was a past president of IMA, Payyanur. And he also presently is an executive committee member of Cardiological Society of India, Kerala chapter, and president Kannur Cardiology Club. So we'll be talking today on management of dyslipidemia and clinical practice. The topic is important for all of us, irrespective of our specialties, because all of us encounter patients with dyslipidemia in our public, friendly, and family groups. So let us hear from the expert, management of dyslipidemia in clinical practice. So invite Sir for the talk. Thank you.
Next slide. Next slide. Okay. Back again. Mr. President, senior colleagues, and my dear friends. First of all, I take this opportunity to thank the office bearers of Kannur IMA for inviting me to give a speech on your weekly meeting. Unfortunately, I'm not a member in Kannur. I'm a member of Payyanur IMA and slowly planning to shift to Kannur. I thank Prasad for nice words of introduction. Today, we'll discuss a common topic, that is management of dyslipidemia. So why this topic is important? Dyslipidemia, otherwise commonly called as hypercholesterolemia, the treatment has a lot of myths and misconceptions, even among doctors. So there are so many proponents against the use of cholesterol-lowering medicines, and so many people feel that cholesterol need not be treated at all. So, but we should have an idea what is the current status of recommendations about cholesterol management and what's the importance. So, mainly, it's important to our specialty because cardiovascular disease remains a leading cause of morbidity and mortality worldwide, despite improvements in the outcome because of newer medicines and interventions. Because of newer treatment modalities, more patients are surviving their first cardiovascular event, but they are at an increased risk of recurrence. So that is the importance of secondary prevention. The prevalence of some of the risk factors, notably diabetes and obesity, is increasing. And of the modifiable risk factors, this dyslipidemia has been shown to be the most strongly associated with myocardial infarction. Whom should be screened for dyslipidemia? Subjects with clinical cardiovascular disease and clinical conditions with increased risk of cardiovascular disease, all adult men more than 40 years of age, or adult women more than 50 years of age, or any postmenopausal women, offsprings of patients with severe dyslipidemia, family members of patients with premature coronary disease. So all these group categorize for a checkup for dyslipidemia. What do you check? You check the total lipid profile. So it contains the total cholesterol, triglycerides, HDL cholesterol. LDL cholesterol is usually calculated by a formula, so Friedewald formula, and VLDL is 1/5 of triglyceride. It is again not estimated. This Friedewald formula is LDL cholesterol is equal to total cholesterol minus HDL cholesterol minus VLDL. That is VLDL is triglyceride 5. This method is valid only for values obtained during fasting state because triglycerides can vary with food. So it is more relevant in fasting state and becomes increasingly inaccurate when triglyceride levels are greater than 200 milligram percentage. And it is invalid when triglyceride values are more than 400 milligram percentage. So there comes the importance of direct measurement of LDL. So some labs do the direct measurement. So it is not recommended, not required in all cases, only when the fasting triglyceride levels are more than 250 milligram. And in patients, those with diabetes or non-vascular disease, a fasting sample may be relevant. But even in such cases, what we know, because of poor compliance of this fasting lipids, because they come to us for a checkup, they may not be fasting. So people started doing non-fasting or a random lipid profile. So it's again very good. It's a very good tool. So non-HDL cholesterol is a better indicator in such settings, especially when the triglycerides is high. So with the random sample, the only abnormality you get is a high triglycerides. So if you take total cholesterol and that minus HDL, that is non-HDL, and generally the treatment target for non-HDL cholesterol is around 30 milligram percentage higher than the LDL targets. If your LDL target is 100, non-HDL is 130. So LDL target is 130. The non-HDL cholesterol target is 160. The LDL target is 70. It is non-HDL should be considered as 100 for treating targets. So traditionally we do a fasting sample. Non-fasting samples give similar results for total cholesterol, HDL cholesterol, and LDL cholesterol. Triglycerides are affected by food. For risk estimation, non-fasting has the prediction strength similar to fasting sample. And fasting samples are recommended only for follow-up of patients with hypertriglyceridemia. When somebody has a hypertriglyceridemia and the triglyceride is also a treatment target, then we have to estimate the fasting sample only. There can be a lot of intra-individual variation. If you do a lipid profile in one lab and in another lab next day, there can be some variation. You get 250 in one lab, the 270 in one lab. So it is possible because around 5 to 10% of difference in total cholesterol is possible. Around more than 20% variation triglyceride is also possible. This could be due to analytical variation or environment factors like diet, physical activity, and sometimes seasonal variation. The recommendation for lipid analysis as treatment targets in prevention of cardiovascular disease. So the target is LDL cholesterol. That's the primary treatment target. So usually when we see the lipid profile, especially on follow-up, we mainly concentrate on the LDL cholesterol. In random sample, sometimes the triglyceride is very high. Then we see the non-HDL as the secondary treatment target. And ApoB is the apolipoprotein for LDL. If it is available, that can be secondary treatment target. In situations where you don't have facility for assessing the lipid profile, or in a patient who cannot afford a lipid profile, you can take total cholesterol as a target. This HDL cholesterol or ApoB, ApoA1 ratio, non-HDL to HDL ratio, they are not considered as treatment targets. Though some reports give all these ratios, they are not that important when you treat a patient. So how do you modify this cardiovascular disease and also dyslipidemia? Initially, it's lifestyle modification. In patients who smoke, you have to recommend to stop smoking. In patients who don't smoke, advise them not to start. And diet should be a healthy diet rich in saturated fat, with mainly focus on whole grain products, vegetables, fruits, lean fish, and poultry. And we recommend physical activity, 2.5 to 5 hours of moderate intensity physical activity per week, or 30 to 60 minutes of physical activity on most of the days, at least 5 days a week. And body weight should be optimized. So it should be maintained between 20 to 25, BMI of 20 to 25, or a waist circumference, which is a better indicator of less than 94 centimeters for men and less than 80 for women. So what are the lipid lowering agents available? So this is a diagrammatic representation of the mechanism of action of different agents. Agents like the statins, ezetimibe, bile acid presents, niacins, and newer agents are also there. I will come to that. So statins are the mainstay treatment of lipid lowering therapy as of now. It is called an HMG coenzyme reductase inhibitor. It reduces the synthesis of cholesterol in the liver. So when you reduce the synthesis of cholesterol, more cholesterol receptors are expressed on the hepatocytes to take more LDL particles from the blood. So that causes a reduction in the serum LDL because of increased uptake of LDL to the liver. And that causes a decreased plasma concentration and LDL and other lipoprotein B containing lipoproteins. The LDL reduction with statin is dose dependent. So you have atorvastatin, we have from 5 milligram to 80 milligram, and rosuvastatin we have 5 milligram to 40 milligram, and you have other statins various strengths. It's dose dependent. And there can be a considerable inter-individual variation in the response. So 40 milligram triglyceride, 40 milligram of statin, atorvastatin for 200 milligram of LDL cholesterol may not produce the same effect in everybody. What are the causes of poor response to statin? It could be due to poor compliance. It could be due to genetic variation in cholesterol metabolism and also genetic variation in statin absorption and metabolism. And secondary conditions like hypothyroidism, renal disease, and all these are all could be a cause of poor response to statin. Statins are one of the most studied drug in cardiovascular prevention. It substantially reduces CVD morbidity and mortality. It slows the progression of and promote regression of atherosclerosis. It's effective both in primary and secondary prevention. The primary prevention is before somebody develops a cardiovascular disease, either stroke or heart attack, in a patient with a high risk for this disease like diabetes or multiple comorbidities, or even an isolated LDL value very high, LDL more than 190. So they are more prone to develop heart attack and stroke. So in such situations, it is very effective as a primary preventive agent, and it is effective in both genders and in all age groups. The studies have shown that each 1 millimole per liter, that's around 40 milligram per deciliter, LDL reduction offers 10% reduction in all-cause mortality, 20% reduction in cardiovascular disease mortality, and 23% reduction in major coronary events, and also a 17% reduction in the stroke with no increased risk of any non-cardiovascular disease death. So this is the safety and efficacy of statin. So many trials on secondary and primary prevention shown that when you bring down the levels of LDL from somewhere around 150 to 200 to as low as 70 or 50, there's a significant reduction in the cardiovascular events, both in primary prevention setup and the secondary prevention setup. The clinical benefits of statins are independent of the type of statin. There is nothing called rosuvastatin is more effective or atorvastatin is more effective. It all depends on the dose what you are giving. And the benefits depends on the extent of LDL lowering. So that's the main idea. So we have to identify the LDL goal. In high-risk situations like an isolated LDL of more than 190 on at least on 2 assays by 1 to 4 weeks, or a patient with a clinical cardiovascular disease, or a long-standing diabetic with more than 10 years diabetes. In all these situations, they require what is called a high-intensity statin. When you say high intensity, we aim at least 50% reduction in the LDL. So we have to select a statin and a dose which can bring down the cholesterol LDL level by 50% or more. So calculate the percentage of LDL reduction required and choose a statin and a dose that can provide this reduction. And consider drug combination if you don't get the effect with statin alone. So this is a general idea about how much should be the cholesterol in different settings. So if you check only the total cholesterol, it should be definitely less than can I go back? Okay, it should definitely less than 200. And in low risk individuals, the LDL treatment target is around 130 milligram percentage. In moderate and high risk, it should be less than 100. In very high risk patients like patients already had an ACS, should be less than 70. And in extreme risk patients with multiple risk factors and coronary disease, it should be less than 55. And non-HDL targets are generally 30 millimeter above the goal. And triglyceride, the accepted level is less than 150 milligram. For patients with atherosclerotic cardiovascular disease who experience a second vascular event within 2 years, while taking maximally tolerated statin therapy, an LDL goal of less than 40 milligram per deciliter may be considered. That's the recommendation. So patient already had an event, and within 2 years they have a second event, then our treatment target is much lower. So this is how you select a statin and the statin dose. When your aim is to reduce LDL by more than 50%, there are only 2 agents recommended. One is atorvastatin and rosuvastatin. That too in a dose of 40 to 80 milligram atorvastatin per day or 20 to 40 milligram rosuvastatin per day. When our aim is to bring down the LDL by around 30 to 50%, that's a moderate intensity statin. You can use atorvastatin 10 to 20 or rosuvastatin 5 to 10 or simvastatin 20 to 40 or other statins as given in the list. When your aim is only a low intensity statin requirement to produce LDL reduction by less than 30%, then other agents like simvastatin, pravastatin, lovastatin, they are the agents recommended. Drug combinations of statin, there are various add-on to statin to give better efficacy, or better lowering of LDL, or when get additional lowering of triglycerides if required. Ezetimibe is a quite commonly used drug. It provides an incremental reduction in LDL by 15 to 20% in addition to statin. Then another is called this PCSK9 inhibitor. They provide a further reduction of around 50 to 70%. They are very potent drug. In high-risk patients with triglyceride more than 200 milligram percent, despite statin therapy, fenofibrate may be added. If it was statin on other lipid parameters, statin can reduce the triglyceride by around 30 to 50%, can cause an increase in HDL by around 5 to 10%. And adverse effects. This is what so many people are worried about using statin. The 3 important side effects which are recommended. One is the muscle side effect. The other is liver toxicity. The third is the induction of diabetes. The most severe form of statin-induced myopathy is called rhabdomyolysis. It presents with severe muscle pain, muscle necrosis, myoglobinuria, and renal failure. And if you check creatine kinase, it may show an elevation of 10 to 40 times the upper limit of normal. But the frequency of this condition is very, very low. It is around 1 to 3 per 100,000 patient years. So it's very low. So one need not worry about this condition too much when you prescribe statin. Only thing is that you should be aware of this condition. The most common variety of statin-induced, so-called statin-induced myopathy, I will say, it is myopathy without CK elevation. The actual frequency is unclear. It may be around 5 to 15%, and symptoms are often vague. So some people may come in a typical myopathy, they will have severe pain in most of the skeletal muscles. They cannot move the upper limb, either upper limb, lower limb, and on touching it can cause severe pain. That is the definite symptom which we consider. This is vague symptoms, and the association with statin treatment is also difficult to confirm. People say the frequency or incidence is almost the same with the placebo. So you are not very sure about whether it is due to statin alone or not. So in such situations, what we do is, if they really require statin, you give the highest tolerable dose. Even you not give daily, you can make it alternate day or twice a week, something like that. So to give the desired or at least reasonable reduction in the LDL cholesterol. Then the other is liver toxicity. Mild elevation in ALT can occur in 0.5 to 2%. And we take it significant when the SGPT or ALT is more than 3 times the upper limit of normal. Generally, upper limit is around 40, so more than 120, we consider it significant. But the progression to liver failure is extremely rare. And in patients with, we see a lot of patients with fatty liver and dyslipidemia, fatty liver and hypercholesterolemia. In such patients, they have a baseline elevation of ALT or SGPT. In such patients, it is shown that statin doesn't cause much further elevation in ALT. So we can safely give statin, monitoring the ALT. Risk of new onset diabetes, let's say absolute risk around 0.2%. The risk is higher with more potent statin at higher doses in elderly, overweight, and patients with insulin resistance. But the absolute reduction in cardiovascular disease risk outweighs the risk of small increase in the incidence of diabetes. So the recommendation is, even if there is a mild rise in the diabetic status, you have to continue statin and you control the diabetes. So that gives a better outcome overall. There are some drug interactions with statin, mainly because of this hepatic metabolism via cytochrome P's. So these are some of the groups which can interact with statin, produce more incidence of myopathy and rhabdomyolysis, like the antifungal agents like itraconazole, ketoconazole, then antibiotics like erythromycin, clarithromycin, and antihypertensives like calcium channel blockers, and cyclosporine, amiodarone, ranolazine, grapefruit juice. So it's another thing. So these are, and also gemfibrozil as a triglyceride lowering agent. So a combination of statin with fibrates. So fibrates are generally prescribed for triglycerides. And so this combination may enhance myopathy. So we have to be more careful. The highest risk is with gemfibrozil, and the risk is lower with fenofibrate. This bile acid secrets are a group of drugs which can reduce the LDL with no significant effect on LDL, HDL. But because of GI side effects, these drugs are not commonly used. Ezetimibe is a very commonly used drug. It inhibits the intestinal uptake of dietary and biliary cholesterol, reduces the amount of cholesterol delivered to the liver. Liver reacts by upregulating the LDL receptor. When you say upregulating receptor, it takes more LDL to the liver for metabolism. So thereby it reduces the plasma or serum LDL levels. And ezetimibe, fortunately, it doesn't affect the absorption of fat-soluble vitamins. Ezetimibe, generally, it is not given as monotherapy. Almost always is given in addition to statin to produce further lowering. But very rarely in statin intolerant patients, it may be given as monotherapy. It may reduce LDL by around 15 to 22%. Combined with statin, it can produce a further reduction by 15 to 20%. In patients who don't tolerate high dose statin, you can reduce the dose of statin and add ezetimibe. PCSK9 inhibitors, PCSK9 is a molecule, and the elevated levels promote LDL receptor metabolism. So when you catabolism, when you give this molecule will reduce the level of LDL receptor. Thereby, when you reduce the LDL receptor, the cholesterol level will go up. So inhibiting this PCSK9 will cause higher expression of LDL receptor, because LDL receptor catabolism is inhibited. So it produces more LDL receptors, thereby removes more LDL from the blood, reducing the LDL cholesterol. So the two agents are in use. One is alirocumab, that is evolocumab. Both are available. It has to be given by subcutaneous injection once in 2 weeks. That's the recommendation. And the average cost of these agents is around 20,000 per injection. So efficacy in clinical trials has shown that there is an LDL reduction around 50 to 70%, reduction in cardiovascular events, no major effect on HDL and triglycerides, and effective in majority of patients. In combination with statin therapy for LDL reduction in individuals with familial hypercholesterol, that is one indication. And in individuals with other cardiovascular disease who are unable to reach LDL or non-HDL goals, with the maximum tolerated statin plus ezetimibe. Then we can give these agents as an add-on to statin plus ezetimibe, or in patients who are intolerant to statin, either allergic or they have significant side effect, muscle side effect to statin. As a monotherapy, you can use these agents. Nicotinic acid, even though it was popular long ago, now because of major side effects is not being used. So the recommendation for pharmacological treatment of hypercholesterolemia. So prescribe statin up to the highest recommended dose or highest tolerable dose to reach the goal. So that's the class 1 recommendation. And another class 1 recommendation is if the goal is not reached, it should be combined with a cholesterol absorption inhibitor like ezetimibe. And another class 1 indication is in patients with very high risk with persistent high LDL despite a treatment with maximum tolerated dose of statin plus ezetimibe, or in patients statin intolerance, you can use PCSK9 inhibitors. Then about triglycerides, the normal triglycerides, the accepted level is less than 150. Borderline high is 150 to 199, high is 200 to 499, and very high is more than 500. This very high levels, more than cardiovascular disease, it is acute pancreatitis. That's the risk is mainly the risk of pancreatitis. Recommendation, again, the first line recommendation for hypertriglyceridemia is statin only. So because statin can produce around 30 to 50% reduction triglyceride levels. So statin treatment may be considered as the first drug of choice for cardiovascular disease prevention in individuals with the triglyceride more than 200 milligram per deciliter. In patients triglyceride between 135 to 490, and despite statin treatment, we can use omega-3 fatty acids. And in patients with triglyceride more than 200, despite statin treatment, you can use fenofibrate. Fenofibrate is not the first line treatment for triglycerides. Management of mixed dyslipidemias, combination statin with fibrate and omega-3 fatty acids as an add-on. For HDL, there are no really effective medicines. Some newer drugs are there. The first, the initial management is by therapeutic lifestyle changes. It causes a 10% increase in HDL, weight reduction, exercise, smoking cessation, and moderation of alcohol consumption. Pharmacology intervention, statins can produce 5 to 10% increase in the HDL. Fibrates can produce 10 to 15% HDL. Nicotinic acid was used to increase the HDL, but it is not being used nowadays. And newer drugs like CTP, initial few drugs in this class were abandoned because of serious side effects. Now one new molecule is available. In patients with acute coronary syndrome, so when patients undergoing PCI, when they present to you with acute coronary syndrome, acute MI or unstable angina, we have to give a high dose statin on admission after taking a sample for lipid profiling. And our aim is to bring down the LDL to less than 50% of the basal, irrespective of the initial LDL level. So that's the recommendation of statin in ACS. And how to monitor lipid lowering therapy? You have to be monitored by checking the lipid profile. How often you check? Before starting lipid lowering agent, you check fasting lipid profile at least twice at 1 to 12 weeks interval, depending on the initial level. Then after starting treatment or 8 to 12 weeks, you recheck it. And if it is at goal, then you have to can monitor long term. If there is a dose adjustment required, again after 8 to 12 weeks interval, then once the LDL is at target, at goal, you need to check only once in 6 to 12 months. That's the recommendation. Then you have to monitor two enzymes. One is ALT, the other is CK. Monitoring ALT before treatment, once 8 to 12 weeks after starting drug or after dose adjustment. Then thereafter, if it is normal, there is no need of routine checking of ALT just for the sake of seeing any statin side effect. If ALT is elevated, less than 3 times, you continue the medicine and recheck the enzyme after 4 to 6 weeks. If value is more than 3 times upper limit, stop lipid-lowering therapy or reduce the dose and recheck after 4 to 6 weeks. Then cautious, after, once you stop it, cautious reintroduction may be considered. CPK should be monitored before starting the treatment. If the baseline CPK is more than 4 times the upper limit, it's better not to start statin. They will recheck the CPK level. Then routine monitoring is not required unless they are symptomatic. So once you have done a baseline, it is normal, and the patient doesn't have any muscle symptom, there is no need of rechecking CPK after that. Check CK if patient develops myalgia. Be alert regarding myopathy and CK elevation in patients at high risk, such as elderly patients, concomitant use of interfering therapy, multiple medications, liver or renal disease, and sporty athletes. If CPK is elevated on statin therapy, first re-evaluate the indication for statin. You make sure that it is really required. If CPK is more than 4 times, then it can be 2 situations. One is more than 10 times the upper limit, then stop treatment and check renal function and monitor CK every 2 weeks. If it is less than 10 times the upper limit, no symptoms, continue lipid lowering therapy while monitoring CK. If symptoms persist, stop statin, reevaluate symptoms after 6 weeks, and reevaluate the indication for statin. Then if statin is really indicated, then consider re-challenge with same or another statin, maybe at a lower dose or alternate day, once or twice a week, like that. So to give the maximum tolerated dose. If it is not possible, then you have to switch on to other medicines like we have discussed. Beyond this, there are a few newer agents available. One is available in our market, that's called bempedoic acid. It acts a little upstream of the statin mechanism. Like it acts upstream of the HMG comes reductase inhibitor. It inhibits LDL synthesis, increases the expression of LDL, thereby more LDL is cleared from the blood, so less LDL is present in the blood. It's effective in an oral dose of 180 milligram daily. And it achieves around 17 to 25% of LDL reduction. It's not like PCSK9. It's just like either can be used as an add-on to statin plus ezetimibe, or in statin intolerant patient, you can give bempedoic acid plus ezetimibe. And the muscular side effects of statin, it is not observed with bempedoic acid. There's another new drug is inclisiran. It's a small interfering RNA targeting hepatic PCSK9. It is effective as subcutaneous injection on day 1, then second dose after 3 months, and once in 6 months thereafter, in a dose of 300 milligram. It's very expensive. I think it's not available in India. It's imported only. One dose may cost around 2 lakhs rupees. It again produces more than 50% reduction in LDL. And it doesn't have major side effect. Can be given in patients on maximum toleration, just like other PCSK9 inhibitors. It's again similar action. It can be given add-on to statin plus ezetimibe. Another drug is evinacumab. It binds to a molecule called angiopoietin-like protein 3. This molecule plays a key role in the lipid metabolism by increasing the level of triglyceride and other lipids in the blood. So loss of function of this molecule is associated with lower levels of LDL and triglycerides. So it is given as an IV injection once in 4 weeks. It again produces 50% reduction in LDL. Can be given with other lipid lowering agents. And there's another agent mainly for triglycerides, especially people with very high triglycerides, more than 1,000, 1,500 triglycerides, with a very high risk of pancreatitis. Then this drug is very effective. It's an antisense oligonucleotide that binds to ApoC3 mRNA, leading to its degradation, prevents translation of ApoC3. Preventing translation of ApoC3 allows metabolism and breakdown of triglyceride and chylomicrons. So administer subcutaneously once a week for 3 months, then once in 2 weeks. Achieves around 77% reduction in triglyceride at 3 months. That's the requirement. They're all new drugs. It's not available in our market. They're all, it's not yet approved by US FDA, but still as a trial, it is being used. So in conclusion, cardiovascular disease continues to be the #1 cause of morbidity and mortality worldwide. And treatment of dyslipidemia is the most effective modified target of improving cardiovascular outcome. Statins are the cornerstone of LDL lowering therapy. Ezetimibe is recommended as an adjunct to statin if LDL goal is not achieved the maximum tolerated dose of statin. PCSK9 inhibitors are available who require additional lowering of LDL cholesterol. Then newer drugs are coming in the market which offer further benefits in selected cases. Thank you.
Thank you, Dr. Raveendran, for the excellent and very informative talk on statins. Now it is open for discussion.
That is diet to be used in dyslipidemia. Definitely. When they say this, around 2/3 of cholesterol comes from the liver. When the diet also plays a role in the rest 1/3. 1/3. 1/3 is not very little. 1/3 and 2/3. It's 1/3. 2/3 is. No. The thing is that liver synthesizes LDL, but it's only the hepatic contribution is around 65%. Remaining 35% is from the diet only. So diet really modifies. No, that's it all. There are a lot of myths about cholesterol, misunderstanding about the statin and cholesterol, even among doctors, even among cardiologists. So many WhatsApp, so many. No, not like that. Because as the knowledge stands today, statin or cholesterol lowering reduces the cardiovascular events, unless some new information comes. No other new information has come so far. So I think we have to believe what is available, what knowledge is available now. It has to be taken lifelong. No, you, especially following an acute event, first 1 year it should be intense only. And our aim is to keep the LDL level to the desired level, what the goal what we set. So the dose required may come down after some time. Fatty liver. No. This doesn't produce fatty liver. Statin doesn't, even it may be beneficial in patients with fatty liver. That's what I told. In patients with dyslipidemia and fatty liver who presents with a high liver enzyme initially, when you, along with statin, anyway, we'll be recommending lifestyle modification also. In fact, the SGPT level comes down of something. So it doesn't increase the baseline LDL in SGPT in patients with fatty liver. Fenofibrate, that's it all. When you combine statin with fibrate, the incidence of myopathy is more, but you should be careful, that's all. So first, even for triglyceride, the first line treatment is only statin. If you don't arrive or reach the goal of triglyceride, even with the maximum tolerated dose of statin, then you can add on fenofibrate. But when you combine fenofibrate or any fibrate with statin, of the fibrate, fenofibrate is safer. But you have to monitor the muscle symptoms. That's all. Fenofibrate. Both statin and fibrate, both cause myopathy. When you combine these two, the incidence is more. But among the available fibrates, so gemfibrozil will cause more myopathy, whereas fenofibrate causes less myopathy. One is symptom. So when somebody has severe muscle symptom, muscle pain, generalized muscle pain, after starting this medicine, then you can check the CK or creatinine CPK. Yeah. In fact, there is no real science behind giving it bedtime. You can give it any time of the day. But somebody will be on multiple drugs. Mostly we give antihypertensive, antidiabetic on the daytime. So we give this bedtime. There's no benefit by giving it bedtime, or that doesn't make any difference. It's bedtime or morning. There are so many patients take everything in the morning because they tend to forget the medicines at night. So nothing like you have to give it in the morning and at night. Yeah. Anybody with established cardiovascular disease, whether they are on medical treatment, they have interventions or bypass surgery. One is there are two types of seeing it. One is you have to keep it at least 50% of what was the basal LDL, or at least less than 70%, 70 milligram percentage. The European Society, they say it should be less than 70%, 70 milligram percent LDL level. Or the American recommendation, they say you keep it 50% of what was the basal. So especially this is applicable when the baseline LDL is less than 140. If somebody had a baseline LDL only on 100 milligram percentage, when they present with acute coronary syndrome, first time without treatment, then our target is 50 milligram. So otherwise, generally less than 70 milligram, or at least 50% of the basal level, whichever is lower. Same thing. Post CPK, post PTCA, or CID on medical management, it is same for everybody. That can be a lot of genetic thing, genetic predisposition to coronary disease. Yeah. No, not no. The studies have shown that if somebody had a normal, so-called normal level at baseline, when they present with acute coronary syndrome or acute cardiovascular disease, stroke or heart attack, they benefit by bringing it down to 50% of what was normal. If you had a LDL of 100 when you present with a heart attack, you benefit. This benefit means with regards to secondary prevention, the secondary symptom or secondary presentations are much less if you bring it down to 50% of the basal. Then I don't think, because this is accepted by all scientific bodies, irrespective of the countries. So I don't think. I will tell my experience. That can be for any medicine in that fact. That can be for any medicine in that fact. To start suspecting, like yeah. No, I will tell you, because when we see in our clinical practice, after the introduction of these high dose statins, we are seeing the recurrent events much lower. One thing, and this US FDA is a body which is not that influential, and they take everything. No, they don't accept everything. So any drug, any stent or any other thing, it is used in every country, including Europe. US FDA doesn't approve unless they are satisfied or they are convinced about it. Even FDA, this is approved by FDA, and all the recommendations come with multicentric studies. Multicentric means in various parts of the world. They may produce mistake. No, not like that. Not like among the different regulatory bodies. I think FDA is a little more stringent than other. Who will evaluate? No, all these studies are most of the studies are multicentric, and then with patients from different countries. saying until any new information is available, we have to believe or accept what is available, what information is available. No, statin, I don't think there should be any significant bias about statin, because statins are available in the market for a long time, now more than 25 years, I think. More than 25 years, it is freely available. Statin, I think it was introduced in India, maybe in the early 90s or late 80s. So I don't think there should not be any significant doubt in regard to statin. Statin really have difference. You see, because previously when we used this higher dose of statin and all, this concept came after 2000, 2005 and all. The real recommendation for higher dose, 40 milligram, 80 milligram came. Before that, we used to see a lot of recurrent events in patients who initially had an event. Now, I think the recurrent event has come down after after the recommendation for higher dose statin came. I think we have to, until a new information or new study comes, we have to believe what is available.
Now my second question.
Ah.
Heard that statins can cause in very high dose of psychosis. Is it true? Statins in very high dose can cause psychosis. Is it true?
I don't know. Like initially, when we were discussing about side effects, so a lot of sleeplessness and other things were recommended. Now they say even if you reduce the LDL, even as low as 25 or 15 milligram, doesn't have any significant side effect in the long run, even for neurological or psychiatric side effects. So I know a lot of patients taking 80 milligram. We usually give maximum 40 milligram, maybe 80 milligram for a few days or weeks. Then we make it 40 milligram atorvastatin. And I have seen a lot of patients prescribed from elsewhere continuously taking 80 milligram statin. I have not seen any neuropsychiatric side effects of statin. Because most of our patients are on statin, and I not come across any neuropsychiatric side effect of statin so far. Myopathy, I have seen 2 cases, and both cases they could not continue statin. And I have seen statin allergy in 1 or 2 patients. That's all. But otherwise, they are tolerating. That's why I told. General recommendations daily. If you are not tolerating daily, you can make it alternate day, or your cholesterol is on the lower side with daily. You can make it alternate day, twice a week. They're all recommended. There are a little longer acting drug. Need not be taken every day like antihypertensive or antidiabetic. Yeah. That's why increased means when I think that's why even if the initial level is up to 4 times the upper limits, 800,000 and all. Normally it's around 200, up to 800,000. If they don't have any symptom, you can. Yeah, that is the symptom, because elevated CPK doesn't mean that it is myopathy secondary to statin. It can be due to a person who is exercising regularly or any muscle trauma can cause it. Injury means injury can be of different causes. It could be a sports injury like any. See, very seldom. A borderline and all is okay. Like any physically active person can cause some rise in CPK. Any muscle, some injury in the local muscle, not generalized, can cause something. Any very physically, any local muscle trauma. Let's say, even though the normal considered is 200, up to 5 times upper limit and all can be taken, or it's not a contraindication for a drug, because it may not increase further with the medicine. Only if they have significant myopathy, they will have symptoms. So. Yeah. Elevate ആണെങ്കിലും there's no need to worry about that because it may not increase further with medicines. മനസ്സിലായേ? That's why if the baseline is more than 4 times, I know, yeah.
Without a muscle damage, can there be an increase in CPK? That was the question. That's not the.
No. Other source, we have to think of other sources of CK. Other sources. Commonest source is muscle. Other body organs releasing CK. Could we do it may be related to metabolism. No, it can be due to metabolism. I don't know. It could be due to altered metabolism also, like that you know.
If no more questions, next is vote of thanks by Secretary.
Our sincere thanks to Dr. Raveendran sir for his excellent and informative talk on management of dyslipidemia. Thank you, sir. Also, I thank all members for attending today's CME. Thank you.
Closed for dinner.